Now let us discuss about the wilms tumor or nephroblastoma, which is actually the cancer of the kidneys in children. Its incidence is 1 in every 10,000 children in the United States. It is the most common primary renal tumor of childhood and the fourth most common pediatric malignancy in the United States. The peak incidence is between 2 and 5 years of age. 95% of the tumors occur before the age of 10 years, and 5% to 10% of the wilms tumors, they involve both the kidneys, either simultaneously or one after the other. Bilateral wilms tumor, they actually have a median age of onset approximately 10 months earlier than the unilateral wilms tumor. So bilateral wilms tumor have actually the earlier onset than unilateral wilms tumors. Now this tumor actually illustrates the relationship between the malformations and the neoplasms, and also tells us about the histological similarities between the organogenesis and oncogenesis. It also tells us about the two-hit theory of recessive tumor suppressor genes. Now what is the two-hit theory? Well, unlike oncogenes, the tumor suppressor genes, they follow the two-hit hypothesis, okay, which says that both alleles that code for a particular gene must be affected before an effect is manifested. This is because if only one allele for the gene is damaged, the second can still produce the correct protein. So in other words, we can say that tumor suppressor alleles are recessive, whereas mutant oncogene alleles are dominant. You will also see the role of pre-malignant lesions in wilms tumor, and also the potential for judicious treatment modalities to dramatically affect prognosis and outcome. Now let us discuss about the pathogenesis and genetics of the wilms tumor. There are some diseases, particular diseases of infancy that are actually associated with wilms tumor. And especially there are 4 recognizable group of congenital malformations, and they are associated with distinct chromosomal loci. So the 4 diseases that are associated with wilms tumor are Weger syndrome, BWS syndrome, and nephrotic West Danish-Ras syndrome. Now let us discuss all of the 4 diseases one by one. The first is WAGR or Weger syndrome, or whatever you want to pronounce it. And the characteristics of the Weger syndrome are actually, it's written in the name. So W stands for wilms tumor, which is present in about 30% of the cases, or if a baby has a Weger syndrome, then the chances of having wilms tumor is actually 33%. They have absence of iris, they have genital anomalies, and they are suffering from mental retardation. So the genetics tell us that there's actually the germline deletion of the short arm of the chromosome on band 13. Actually the 11 stands for the chromosome, the P stands for repeated, this is actually the short arm, and the 13 stands for the band on the short arm of the 11th chromosome. And on that particular area of the short arm of chromosome, or that particular band, we have the wilms tumor associated gene, and we have autosomal dominant gene, which is called PAX6, okay. And obviously the abnormality in the wilms tumor associated gene, or the deletion of autosomal dominant gene for absence of iris, they will actually lead to absence of iris and the wilms tumor in the Weger syndrome, and they both are located on the chromosome 11. Now patients with deletions that are restricted to PAX6 and they have normal WT1 function, so what you would expect, we would expect that they would just have absence of iris and they would not have any risk associated with wilms tumor, because the WT1 is actually WT1 gene is actually functioning normally. Now, the presence of germline WT1 deletion in WAGR syndrome represent the first hit. There is development of wilms tumor in these patients only when there is occurrence of a nonsense or frame shift mutation in the second WT1 allele, and that's called second hit, and that's when you would have the effects of wilms tumors. Then the second disease that is associated with wilms tumor is actually Danish-Ras syndrome, okay. and here you have 90% chances of wilms tumor. Did I just write William? I don't know, maybe Prince William is all on my mind. Anyway, so they have 90% chances of wilms tumor, and in WAGR syndrome you just had 33% chances of wilms tumor. You would also find gonadal dysgenesis, gonadoblastomas, early onset nephropathy, and on histopathological sites you would find the diffuse mesangial sclerosis, which is actually this hardening of the mesangium or the mesangial cells. And these cells are specialized cells around the blood vessels in the kidney and the mesangium. Here genetics tells us that there's actually the germline abnormalities in the WT1 gene. And now, unlike the WAGR syndrome where you have actually the deletion of the WT1 gene, here you have the dominant negative missense mutation in the zinc finger region of the WT1 gene, and because of that there is inability of the product of the WT1 gene to bind to DNA. Okay, now what really happens in the dominant negative missense mutation is that obviously if the gene is mutated, then there must be a defective protein product. Now that particular defective protein product of that mutated gene, which was actually the dominant negative missense mutated gene, this antagonizes the products of the normal allele, and it is sufficient only in causing genitourinary abnormalities. It does not cause any kind of tumor. Okay, so this syndrome, as you can see, is actually restricted to genitourinary abnormalities. This wilms tumor associated gene 1 codes a DNA binding transcription factor, that is its product, and this is expressed within several tissues that includes kidneys and gonads during embryogenesis. And this WT1 function as a transcriptional activator or repressor. Okay, it can either act as a transcriptional activator or repressor, and that depends on which tissue on which cell it is present. And if it is actually a transcriptional activator, then obviously it must target some particular proteins. So the transcriptional targets of WT1 include glomerulopodocyte specific proteins and the genes that are associated with inducing differentiation. Now, despite the importance of WT1 in the nephrogenesis and its role as a tumor suppressor gene, remember that only 10% of the patients with wilms tumor actually demonstrate the WT1 mutation. So you see, in 90% of the cases, there is no relationship between the wilms tumor and the WT1 gene. And so this tells us that the majority of these tumors, they arise by genetically distinct pathway. The third disease that is associated with wilms tumor is actually Beckwith-Wiedemann syndrome, in which you have, everything is enlarged, kind of such characteristics, because you have organomegaly, microglossia, which is actually enlarged tongue, a hemihypertrophy in which one side or one part of the body is actually larger than the other, you have omphaloceal, and in which there's abnormal development of the abdominal muscle, in which intestines, liver, and occasionally other organs remain outside of the abdomen in a sac. And you have adrenal cytomegaly. Now, in this, the genetics tells us that instead of actually any abnormality in the WT1 locus, we have an abnormality in WT2. And this WT2 gene is actually present on the short arm of chromosome 11, but the band is different. Here the band is not 13, here the band is actually 15, and subband is 5. And unlike WAGR or Dennis-Dry syndrome, the genetic basis for BWS is considerably more heterogeneous in that no single gene is actually involved in all the cases. Okay. The phenotype of BWS, that is including the predisposition to tumorigenesis, is influenced by the specific WT2 genomic printing abnormalities. Okay, so here you have a genomic imprinting abnormality in the WT2 gene. Okay, now what is genomic printing? Actually, what really happens is that some genes are normally active only when they're inherited from a person's father, others are active only when they're inherited from a person's mother. There are actually only some of the genes that follow this pathway, otherwise most of the genes are actually activated whether they come from paternal side or maternal side, but somehow some of the genes are active only when they're inherited from a person's father, and some are activated only when they're inherited from a person's mother, and this phenomena is known as genomic imprinting. Okay, so genomic imprint, because some of the genes would be just imprinted and they would be inactivated. So whenever you think of the word imprinted genes, you would think that these genes are actually inactive genes. Either they can be inherited from mother or father, but they would never be activated in that particular person. But for some reason, if these imprinted genes become activated, then you have tumor-like pathology. Now, one of the genes in this WT2 region is actually insulin-like growth factor, which is IGF-2, and this is normally expressed solely from the paternal allele. Okay, while the maternal allele is actually silenced by the imprinting, that is, the maternal allele is actually the imprinted or the inactivated gene. Some wilms tumor, you would see that there's actually loss of imprinting, that is, the genes that should be inactivated are now activated. So this is actually the re-expression of the maternal IGF-2 allele, and that leads to overexpression of the insulin-like growth factor 2 protein. And because this insulin-like growth factor 2 protein is an embryonal growth factor, and this explains the features of overgrowth, which is actually associated with this syndrome. You had seen adrenocytomegaly, microglossia, organomegaly, and all those megaly things. So of all the WT genes, the imprinting abnormalities of the insulin-like growth factor 2 have the strongest relationship to tumor predisposition in BWS. In addition to wilms tumor, the patients with BWS are almost at increased risk for developing hepatoblastoma, pancreatoblastoma, adrenocortical tumors, and rhabdomyosarcomas. And there's actually very strong relationship in about 10% of the wilms tumor cases between the wilms tumor and the gain of function mutation of the gene encoding beta-catenin. Okay, and the fourth group of recognizable disease that actually has a very strong association with wilms tumor is actually the nephrogenic rest. Now, these are the fragments of the embryonic tissues that are present in the kidneys and are retained after the period of embryonic development. And there are the precursor lesions of the wilms tumor, and they are seen in renal parenchyma adjacent to approximately 25% to 40% of the unilateral wilms tumor, and this frequency rises to nearly 100% in cases of bilateral wilms tumors. And in many instances, the nephrogenic rest share genetic alterations with the adjacent wilms tumor, underscoring their pre-neoplastic status. And it is important to document the presence of nephrogenic rest in the respective specimens, since these patients are at increased risk of developing wilms tumor in the contralateral kidney, and they require frequent and regular surveillance for many years. Thank you.